Well, thank you very much for what I assume was a nice introduction to me, and she could actually have said almost anything, I'm afraid. I will not try to speak French because it's quite poor. I apologise for that. I will try and make up for it by giving you an exciting and interesting presentation, albeit in English. So I wanted to talk to you about an ongoing piece of work that I'm leading with my team of researchers over in Newcastle, which focuses on the role of austerity, recession, on health inequalities, particularly looking at health inequalities between proximal neighbourhoods, so health inequalities within one town, what happens during a period of austerity. And the town that we're looking at is called Stockton-on-Tees. It's in the northeast of England, in a fairly, the northeast of England is a fairly deprived region of England, formerly industrial, so a post-industrial region. And these are just some photographs of the town as it looks today on the right, and as it looked in the 1930s here on the left. And we will return to this historical dimension later in my talk. Okay, so what I will be talking about is some of the background to the project, what inspired us to put in the application, why it got funded, and what the kind of intellectual and conceptual background was in terms of thinking about previous research on the effects of recessions on health and where some of the gaps are in terms of austerity, and this focus on the local, on a local case study. I'll then talk about some of the methods that we're using in the project, because it takes a more holistic approach combining quantitative, qualitative and historical research. And then I'll talk through some of the emerging results. The project is just over halfway through, but we've got some research results coming from both the quantitative and the qualitative work packages. So to start, some of the background: when the financial crisis hit, there was suddenly a re-interest amongst public health academics, social scientists, around the effects of recessions on things like inequality, but also on public health and inequalities in health. There have been a lot of research on recessions in the 1980s, a little bit in the 1990s, particularly in places like Sweden, where they had a recession in the 90s, and also after the Asian crisis in the early 2000s. And I think we find with research that actually it comes in peaks and troughs, and of course our research needs to reflect the real world and what's happening. So there was a resurgence of interest about 5 or 6 years ago in public health around the effects of economic recessions on health. And I've provided a very brief summary of what the research up until this current financial crisis, so the research from the 80s and the 90s, for example, what did it show in terms of the effects of recession on health? And one of the things from this literature that was quite surprising is that the effects of recessions are not always negative. So there's a kind of a good element from a health perspective of recessions. There are some negative, some bad elements. And then there's also what I call the kind of ugly effects, where the results are less clear, which is around the effects on health inequalities. So the research has shown that it's actually economic growth rather than recession that can be damaging for population health on the whole. So looking at things like all-cause mortality is actually reduced during recessions, and so is tobacco and alcohol consumption, and also road traffic accidents. And there are various explanations to why this might be the case. Road traffic accidents being a simple one in terms of less people are working, there's less productivity, so there are less car journeys, so therefore there are less road traffic accidents. In terms of the more negative effects of recessions on health, then there are deteriorations in things like self-reported health and increases in mental health, and suicide has particular increases, and I'll show some slides that detail that a little bit more And of course we need to think about some of the social determinants of health and how these change. So unemployment increases and job insecurity increases during recessions, and we know that both of these, for people affected, have a negative effect on their health. So for example, meta-analysis has shown that unemployment leads to roughly a double of the risk for mortality, as does job insecurity. And the ugly element, of course, obviously I wanted to have a little, picture. The ugly element is where there's less clarity in research from the 80s and the 90s, largely because health inequalities had not really been examined very much in regards to the question of recession. So there are some issues there, there are some studies, but there's not enough, I don't think, to have a real full answer. So just to talk through this a little bit in more detail about the role of recession, then this table shows some work by Room and Miller, which is looking at what happens to mortality if you have a 1% increase in the unemployment rate. And this is done on modelling. It's a modelling study by economists, and they're only looking at the US. And a lot of the literature does come from the US, so it may or may not be applicable to other countries like Canada and Europe, where there are more sophisticated welfare and healthcare systems. However, we can see from this that all-cause mortality would be predicted to decrease by around 11,000 deaths, and then you can see that for the majority of causes there would be a decrease predicted if there were an increase in the unemployment rate. The major exception is suicide, which you can see has an increase here of around 600 deaths. So this is some data from colleagues at the universities of Oxford and Liverpool over in England, and they've been doing some studies looking at what has happened to suicide rates in Europe, the US, and also within the UK during the last, since 2008, what's happened with the financial crisis to the suicide rates. And we can see here the trends where in Europe there's a decrease in suicide rates over time until the crisis hits, and then there's a sudden increase. There's an immediate kind of reaction in terms of mental health at that very severe end of mental ill health with the effects. Here for the US we see a similar increase, and there's a proportion of additional deaths that could be attributed to the recession of 2008. Again, similar pattern within the UK, where it's separated here by men and women, which provides an interesting, because we can see that for both men and women in the UK, suicide rates increase in line with increases in unemployment post-2008. This is particularly interesting because whilst the increase for women is significantly less than it is for men, there is still a response. And that's quite new because historically there hasn't been so much of a relationship between increases in unemployment and suicide amongst women. Suicide rates are much lower in general amongst women, and inequalities in suicide rates are much smaller amongst women than amongst men. So if we want to think about the ugly part of the literature around the effects of recession, then it does come into health in regards to health inequalities. And I've just picked out a few studies. There are not very many that, as I've said, that predate this financial crisis, and the ones that do exist are from very different countries, and they have fairly mixed results. So for example, a Japanese study finds an increase in occupational inequalities during after the Asian economic crisis, whilst a Finnish study finds a slowdown in the trend towards increased inequalities. No effects in a study that compares various Scandinavian countries, whilst others suggest that actually, again, Sweden is perhaps protecting its population from increased negative inequalities effects. More recent study from England has suggested that actually there's beginning to see increases in inequalities, particularly in mental health, during this last recession. So that was some of the wider background to where the Stockton Local Health Inequalities Project sits. But of course we weren't just interested in recession. The financial crisis 2007-2008 was responded to in a different way from previous recessions, particularly in some countries, particularly, for example, in Southern Europe, but also particularly within the United Kingdom. So the issue was that austerity was used as a response. So austerity being decreases to public expenditure and or simultaneously increasing taxes at a time when you've got negative economic growth, so at a time of recession. So cutting when perhaps the need for support and spending is actually greatest. So out of this came some very prominent work by David Stuckler that you might have seen on the body economic, How Austerity Kills. And his research is showing that actually it might not be recessions particularly that matter. So thinking of what I've told you before, recessions might be good for health compared to growth. But actually it's how you respond to that recession, and that actually austerity responses are the problem, that austerity kills, not a recession per se. And so they examined particularly things for mental health and suicides, looking at comparing, for example, Iceland, where there was a response with a fiscal stimulus, compared to countries like the UK or Spain, where the response was one of austerity and reductions in public expenditures. There's also other data coming from the Asian economic crisis, where countries where they protected budgets, social safety nets, had less of an impact on health than those countries that cut them. I also think historically we can look back and actually see similar trends when we look at things. They wouldn't be called austerity, they would just be called welfare cuts or welfare retrenchment. And we can see some work by Nancy Krieger from Harvard when she examined the effects on infant mortality rates from the 1960s through to the 2000s in the US, and looked at what happened when you get the war on poverty and the expansion of things like the aid for dependent children, for example, so an expansion of the US welfare system, and then what happens then compared to the cuts that were implemented to those same programs during the 1980s and 1990s by Reagan, Clinton and through to Bush, for example. And what she finds in that research is that the infant mortality rates, particularly inequalities in them, are negatively affected during the 80s, but there was an improvement during the expansion in the 1960s, particularly for African American children. Similar results come in terms when you look at the welfare state reductions experienced, for example, in New Zealand in the 80s through to the 2000s, where again there was a reduction in social housing, cuts to taxes, cuts to welfare and social expenditure, and you find increases in inequalities in the time period after these changes. Also some work that I was leading with a colleague of mine who's now at Newcastle as well, Alison Copeland, and we examined with colleagues from the Karolinska in Sweden, we compared what happens over time during a period of recession in terms of health inequalities within England compared to Sweden. And what we found is that the inequalities, particularly for women, increased in England, but they did not increase in Sweden. So it begins to suggest a protective effect for the welfare state, a protective effect particularly if you don't cut that welfare state during a period of economic challenge. So I just want to give you a little bit of detail about austerity in the UK. So it's not a Sex Pistols song, not quite as fun. And we can see here with these three maps, what I wanted to show you is here is how life expectancy at birth is geographically distributed across England. I mean, I've said the UK, I'll get into trouble back home because obviously the map is only of England. I apologise to Scotland particularly. It's just the way our data is collected. Scottish data is collected separately from English data, and the English data is available to easily map within a few minutes. So here's England, and we can see, I'll just point out where I am, which is up here in the northeast. This is Newcastle, and my study site is just below Newcastle, so Stockton-on-Tees, I'll talk about in a moment. So we're up here in the red, which is not good. So red is where life expectancy is lower than the national average. Yellow is where it's around 1 or 2 years around the national average, and green is where it's above the national average. So you can see from this is for men, and it's a similar pattern for women, that actually there's what we call the north-south health divide. And I'm sure all countries have these. It might be the south does worse than the north. But in our case, the north has a health penalty of around 2 years on average. It's lower, 2 years lower life expectancy in the north. So that's how life expectancy is patterned. And this one is showing us how the welfare cuts. So there were big changes, multiple. I won't go into all the details. You can read about them in my book if you're that inclined. Multiple cuts to welfare benefits, including things like having a cap on how much a family can have. You're only allowed payments for a certain number of children. If you have more children, then those children don't get any support from the state. And also big increases in terms of the rent that people have to pay for something called the bedroom tax, which means you have to pay additional money if you're deemed to have a spare room, if you're reliant on those kind of benefits. So you can begin to see it hits the poorest very much more than the more affluent. So that's the patterning of health, not so good in the north, and we can also see these areas around the coasts where we've got red and say yellow, and we can see here the darker green is the areas that have received the biggest cuts per head. So dark green means that on average people in those areas have lost £500 a year. And of course it's not on average. I live in the northeast, but I haven't had a cut at all because I'm not a welfare recipient. So if I'm not receiving, someone else is getting a much bigger penalty. So these are the averages. And you can see that these areas in the south with the highest life expectancy have the lowest cuts. So some of the neighbourhoods there, they're getting less than £50 a head a cut, whereas up here in the northeast, where the need is greatest, there's a £500 cut. So that's kind of blow one. Blow two comes from the local authority cuts. So similar to here, where the municipality will provide certain social services, mending the roads, taking your bins. The cuts here have been around 40%, almost overnight for local authorities. It's to such an extent the decreases, and they've happened so quickly over the last 5 years, that there is an actual threat that some of our local authorities might go bankrupt like Detroit. And this, even saying that, it just seems inconceivable to me that we've got ourselves into that position. But again, as you can see, the darker areas have received the highest cuts, and you can see that the patterning reflects the areas of highest health need. So this is what's been happening in the UK over the last 5 years. So that's the background to the project. The background of the debate around the effects of recession on health inequalities, the problematic nature of austerity and its spatial patterning and how it's hitting the poorest areas. And that's where our project came in terms of thinking, what about this issue of health inequalities, particularly in areas of highest need like the north of England, and particularly when you have inequalities that are very high between different neighbourhoods. So most of the evidence to date had been looking at the general population, not so much on health inequalities, and there's not been much linking austerity to changes in health inequalities. And I also think a lot of the research has been from an epidemiological perspective, and there's nothing wrong with that, but also other disciplines like anthropology, sociology, and indeed history can also contribute to our understanding of what's happening and the possible implications. So we wanted to put forward a more holistic, mixed methods approach involving a very local case study and adding in this geographical element. So you're probably all thinking, why Stockton-on-Tees / where the hell, what the hell is Stockton-on-Tees? Which would not just be because you're in Canada. That would be the response by a lot of people in England as well who would not know where Stockton-on-Tees is. It's not a big city. It is a small to medium-sized town. As I pointed out before, it's in the northeast, as we can see that Newcastle's here, and it's down towards the south, just bordering Yorkshire. So that's where it's geographically located, and obviously you could see from the maps before, it's an area of lower than average life expectancy in a region of lower than average life expectancy. And this is just some data here that shows that. So Stockton-on-Tees is over here, and for all indicators apart from one, it's doing far worse than the English average. So for things like life expectancy at birth, healthy life expectancy and so on, for everyone other than women, it's women's healthy life expectancy is doing very negatively. And that's the rest of the region is also a very, very red place to be. I used to be able to make jokes about that politically as well, because it used to be a very strong Labour area. But any of you who have been following English politics, we cannot guarantee anymore that poverty means a vote for socialism. This is some pictures of Stockton, just so you get an idea that it's a post-industrial area. That's how it kind of used to be. There's been some regeneration, including there's a campus of the University of Durham, and I actually used to work there. There's a campus there. This picture here, it's always a test if people know who this is. And one of my students saw me preparing the slides. And he said, "Oh, who's that?" And I said, "Who do you think it is?" And he said, "Is it Theresa May?" And I was like, almost. So for some of the younger members, you can be forgiven because you're not English. That's Mrs. Thatcher, and she did a famous walk in the wilderness, it's called, walk in the wilderness, called by the journalist, in 1987, where she came to survey the destruction that her policies, her economic and employment policies, had created in the north. Basically, there was very, very rapid deindustrialisation, disinvestment, and Stockton and Tees and places like it overnight had, went from almost full employment to having unemployment rates of 15 to 20% and so on. So she's not a popular person in that part of the country. But the kind of nice story is that exact spot where she is now a university campus. So there has been some regeneration. But we will see, not for everyone and not enough to overcome the problems. A campus might employ 1,000 people, but on the riverside there would have been engineering companies employing tens of thousands until the mid to late 80s. So Stockton was convenient for me. It's in the northeast. It's easy for me to do the research there. But intellectually, it has a very kind of enviable position because it has the highest health inequalities of any town or city in England. So these two neighbourhoods, this is a picture of the town centre, and you can see boarded up social housing. And this is one of the suburbs called Hartburn. You can see a nice, very attractive old English style house, very aspirational area. But we can see here that these two places are only 2 miles apart, here and here. But in life expectancy terms for men, they're 17 years apart. So that's a huge gap. I was asking Louise earlier what the gap is between neighbourhoods in Montreal, and she said it was 10 years. And I'd become so kind of immune to this that I just said, "Oh, that's not much." That's not much. That's not good, is it? That's not good that that's how we think. But this is why I said it, because it's 17 years for men and it's 12 years for women in this, as I've said, not particularly large place. And these are just some of the trends over time. So you can see it's been a fairly consistently large gap over sort of a 10 to 15 year period. So this was the place we wanted to research, wanted to see what happens to this place that has the highest health inequalities in England, what happens during a period of austerity and cuts to welfare. So we were thinking, what happens to the gap between these neighbourhoods, but in terms of morbidity particularly, and what explains that gap in terms of the kind of behavioural, psychosocial and material determinants of health. And then also I wanted to relate that to the history of the town, and obviously I've given you a few little snippets about it, how it used to be, how it might be, but looking back even further in time. There's a lot of comparisons in the media particularly between the Great Recession of the financial crisis 2008 and then the Great Depression of the 1930s. So I wanted us to think about that in relation to this one particular place. What happened in the 1930s, what happens now in terms of the social determinants of health inequalities. So this is my team, and you will meet them as we go through the next couple of slides. So methodologically, wanted to have different types of data collection, different types of methodologies contributing to answering these questions. So we have a work around using a survey and using secondary data sources, a work package around ethnography and qualitative research, and a work package using more historical and archival oral history and so on. I won't go through all of this in minute detail, but this is one of the kind of the main pieces of work was to do a random household survey, collecting very thorough data. It was a sort of a 30 to 40 minute face-to-face interview, and then we had telephone follow-ups of about 20 minutes to half an hour over an 18-month period between 2014 and 2016, asking people about their health, but also about various determinants of health, including things like what benefits they might be receiving, what their income, their education, their use of healthcare services, and their use of things like food banks, which I will come on to, as they are the latest development in poverty in England. And this is the team, so you can see from their backgrounds that have people ranging from epidemiology and statistics through to social policy and sociology working on this survey. So this is just looking at the from the baseline results we were looking at. You can see that the nature of the sample and that the differences between the most deprived neighbourhoods, so those where the life expectancy is the lowest, and the most affluent one, where the life expectancy is the highest. And we can see that in our sample, for example, housing benefit is a welfare benefit, but it's only paid to people who are below a certain income level, so it's quite a good indicator of the kind of socioeconomic status of a neighbourhood. And we can see that in the least deprived, only 4% of households received it, whereas in the most deprived, it's well over 50%. So we would expect that, given the gap in life expectancy. And this is looking at some of the health conditions, about how many people had different types of health conditions, and thinking about what the gap was. And then we use some validated measures which you'll be familiar with, such as the Euro Quality of Life, EQ5D, the Warwick Edinburgh Mental Health Scale, and the short form 8 in terms of mental and physical components. One of our questions you want to answer was, yes, there's a gap, but what explains it? And you might know about the kind of context composition debate in terms of explaining geographical inequalities in health. Is it the health of the people, or the characteristics of the people in a neighbourhood that determine its health, or is it something to do with the place itself? So we're using the data we got from the survey. We did some modelling to look at the different compositional, so looking at behavioural factors, smoking, alcohol and so on, psychosocial, loneliness, control and so on, material, income, access to resources, and the environment. So looking at the place in terms of physical activity, physical environment, social environment, and so on. And we wanted to see, for the different measures, what would explain the gap, what's explaining these inequalities. And so some complicated modelling was done by the statisticians to come up with these percentages showing. And I think the highlight from it is that, counter to the majority of public health discourse, behavioural factors on their own were accounting for very little. So less than 10% of the morbidity gaps between these two neighbourhoods was accountable for behaviour. The majority came from material and psychosocial, with a decent role for the environment, at least in 2 of the validated measures. And of course, clustered is showing the interaction between context and composition, which those of you following that debate will know is the kind of the where the debate currently is that it's not one or the other, that they are mutually reinforcing and shaping. We've started to do the analysis of our follow-up and looking at the gaps between the different areas. This is just showing the decrease, unfortunately, in our sample size. We are fortunately within power for the analysis. Few, as you can imagine, that was a bit stressful, but quite a big dropout, unfortunately, over that time period, particularly towards the end. But this is showing, using this data, that the gap, so we get the gap between the affluent and deprived areas, how it changes. And we can see that for the majority of the measures, so there's the 2 mental health measures, and then this is the general health and the physical health. So for the majority, there is not much change. There's no sort of big trend in changes with the inequalities, apart from for the physical health gap. So the physical health gap increases. And we're just at the moment trying to work out why that might be the case and what it means, and redoing some of the modelling to see if the social determinants of health have changed over time and how that might have affected this gap. One of the reasons there might not be much change is obviously it's not a very long time period. 18 months is not a very long time period, but we are beginning at least to see things certainly haven't got better, put it that way. Okay, the qualitative and ethnographic package, got 3 people working on this, a couple of PhD students and a postdoctoral researcher, and they've been looking at the kind of what the place is like in urban ethnography, looking at mental health, interviewing people who have got mental health, pre-existing mental health conditions, and what their experience has been over the last couple of years, and then also particularly looking at women. So in the UK, those cuts that I was telling you about have particularly affected women more than men. They've been negative for poor groups, both men and women, but particularly negative for women because of the associated issues around cuts, for example, to support for children, which is predominantly still provided by women. So one of the things that has been worked on is that Kaylee has been doing some ethnographic work within a food bank. So I know Canada has had food banks, and they were a kind of a new thing in England, a new response, in many ways a positive thing, that charitable sector has responded so well and is providing this support. But in a bigger picture sense, it's an extremely negative thing, because the fact that the charitable sector has had to respond on this occasion, whereas it hasn't had to in the 90s or the 80s, it means that the charitable sector is having to fill what was once provided by the state. So it's a big retreat of the state for us in England. And Kaylee spent about 2 years volunteering, working, observing and interviewing people. And she published a book which was got a lot of publicity within the UK about what the experiences of people within food banks are, and how actually stigmatising and so on it had been, and why people were in there. So the emergence of food banks created quite a lot of controversy within UK politics, and a lot of rhetoric around how people were using them, not because benefit levels, not because of austerity, but because people were feckless and unable to look after themselves. The usual stuff that is propagated, and stuff that was propagated also in the 1930s as well during the Great Depression. Kaylee's research has showed that actually the reasons people need to use food banks is very much to do with being sanctioned, being prevented from having benefits, having cuts to their benefits, particular issues. It's not just people who are out of work, low paid people were having to use food banks because wages weren't sufficient, and also big tipping points in terms of things like ill health itself leading to poverty and therefore needing food bank use. So Kaylee, some of her key findings were also around this issue about stigma, embarrassment that people were feeling, and that comes across very strongly in the interviews, and very much that it's a last resort, not something that people do on a whim in order to then save their welfare benefits for alcohol, which was the claims of a number of government spokespeople, for example. The final kind of strand that the research is looking at is one of my favourite ones, because it's so different from what we normally do, which is taking this historical perspective. And so Michael is a history student. He's doing a PhD on this, and he's looking at comparing Stockton in the 1930s compared to now. And I've just been reading some of his chapters, and it's actually very scary. There was a coalition government in the 1930s. They started cutting what little benefits there were for people who were out of work. There was a big debate about whether people were hungry because they were poor or whether it was because they were feckless. The parallels between then and now in that kind of political arena were very strong, and also in terms of the struggles that people were having. On a positive note, Stockton had a very reforming, charismatic officer for public health working for the municipality at the time called Dr. George McGonigal. He's a graduate from the Newcastle Medical School, and he was at the forefront of arguing actually it's about poverty. This is about poverty, a book called Poverty in Public Health, one of the first books on that. And he's actually been a bit of an unsung hero within the British public health community. So part of Michael's thesis is very much about McGonigal, about his work. He did a lot of things like introducing childcare centres well ahead of his time, 20 years ahead of that being done nationally. So part of Michael's PhD will be to present McGonigal to a wider public health audience. John's a sociologist, but he's also been doing some oral history looking at the 1980s, so looking about how Stockton was, how it is now, and how people's histories and the biography of that place might be affecting some of the patterns. Because one of the reasons to take a particular place is to try and see not just what can be generalised from that place, but also what is unique in the history of that particular setting. So he's been doing interviews with people who, for example, lost their jobs in the 80s, and then talking also to their sons and daughters and this kind of experience of intergenerational unemployment and so on. So the next steps. We've got about 18 months left. We're just in negotiations with a publisher to do an edited book that will hopefully bring together some of these different strands into one place. Finishing off, obviously, some of the analysis, both longitudinal qualitative work and longitudinal quantitative work. Michael and John are both going to be writing some history books around their research, and obviously supporting staff and students in terms of their future ideas, developing them in terms of going for fellowships. And I will leave you with a positive image of Stockton now. I don't want you to think it's all grim up north in England. It's not. We have some very beautiful places as well. And these are some very beautiful publications that have come to date from the project. So thank you very much for your attention.